Question 17, which of the following vessels is most likely affected? Okay, so right away we know this is a stroke question. A 60-year-old woman presents with sudden onset weakness of the right face, arm, and leg. And spoiler alert, that is all you needed to know. Would you believe that was meant to be underneath those three words? Okay. Right face, arm, and leg. That's the most important thing here. No aphasia, neglect, or visual disturbance. Strength is 3 out of 5 on the right, and reflexes are brisk. Okay, brisk is also an important buzzword. She has no facial droop. Okay, so no facial droop, but does have decreased voluntary movement in the right lower face. Okay, right lower face specifically, also very important. So there's a lot of things that are important here, but really this just one line and that first sentence is really all you need to know. I have seen questions that say something like that and then it ends up being something different. So that's why I still go through and read the whole thing on these stroke questions. So let's start with what brisk means. You've probably seen this before. Brisk simply means upper motor neuron, right? Brisk is out of our reflexes, our deep tenor reflexes, out of 4, brisk would be 3 or 4. If we said that we were hyporeflexic, that's lower motor neuron. So increased DTRs, brisk is upper motor neuron, hyporeflexive or decreased DTRs, lower motor neuron. All right, then we have our right face, arm, and leg. Pathognomonic most of the time, not always, but if you do see this presentation on test day, it is most likely the internal capsule. So that's the little elbow looking thing. There we go. Most likely the internal capsule or the baked bean that I just drew there. But that's not what this question is asking for. It's asking us for the vessel that supplies it. So we're gonna have to be a little more specific. Interesting that they say there's no facial droop. This is probably just to throw you off. I don't know why I say probably as if I didn't write this question. Decreased voluntary movement in the right lower face is really important to think about here. All right, this is what took me 30 minutes to draw out before starting this recording. If we have right lower face, specifically lower face, it's really important and surprisingly high yield to know the cranial nerve 7 distribution. If it's ipsilateral, contralateral, they do things a little differently. And so I'm going to try and point that out for you here. So let's say, just for simplicity's sake, let's say this is the left side of the brain and this is the right side of the brain. Let's follow the green path here. So this is cranial nerve 7 coming from the motor cortex on the left side of the brain. We follow it down until some of it decussates and goes to the contralateral side and some of it stays ipsilateral. So the side that stays ipsilateral, it's going to come down and innervate the forehead, specifically the upper face when it's ipsilateral. On the contralateral side, it splits off into 2 branches. So here's one branch, and then here's the other branch. And the contralateral side, it supplies both the upper face and the lower face. And that's really important. So on the ipsilateral side, again, it's just the forehead. On the contralateral side, it's both. So the question becomes, how do you get just the lower face affected, right? Usually, sometimes we see that. We'll see strokes where it's the entire side of the face, or there's forehead sparing. There can be forehead sparing because both sides of the brain supply the forehead. Right here, you got your blue and your green coming from both sides. Same thing on the other side. But look at the lower face. It's just one on both sides. It's coming from the contralateral cortex. So that's how you can get forehead sparing, but still have cranial nerve 7 affected. If it is an upper motor neuron lesion, so something before the cranial nerve 7 nuclei, which are what I'm drawing here in the pons, if it's at or above the cranial nerve 7 nuclei, then you can get this forehead sparing because you're only affecting the contralateral side of the face. It'll affect the entire face, right? So imagine if I just took a pair of scissors and we just cut these nerves here. That's the peripheral nerve for cranial nerve 7. That would affect the entire face, as opposed to if I just took my pair of scissors and I cut right here. Well, that would come down. We can follow this down here to this arrow. That would affect this side of the face. But look at, we got this blue line here. So we got the blue nerve from the contralateral cortex. So that forehead is fine. What about on the other side? Well, if we follow the green arrow down to number 1 here, that would affect the lower face for sure, because there's no contralateral or ipsilateral. There's no other supply to that lower face. As opposed to number 2, yeah, sure, we lost the green one to the forehead, but we still have the blue one. And that's what's really important to understand. And I wrote it out here. The forehead receives innervation from both cortexes. So that's why sometimes, depending on where your lesion is, if it's upper motor neuron, then it can be just the lower face that's affected with forehead sparing. The lower face only receives innervation from the contralateral cortex. So again, if we have a lesion cutting all of them, a peripheral nerve lesion, then you will have the entire face affected. Otherwise, if you're at or above the cranial nerve 7 nucleus, then you end up with the forehead sparing. Now let's talk about how we know this is coming from the internal capsule as opposed to, say, the cortex, right? Because we could have a green here is our middle cerebral artery territory. The yellow is our anterior cerebral artery territory. If we had an MCA stroke, that would knock out the face and the hand, but the foot, the lower extremity, would be unaffected. So that's honestly the principal reason why. So then how does the internal capsule actually capture the entire side? Well, it's because it takes all these tracks, right? All these tracks have to run down through a single point. They come down from the cortex and they all meet up right at one point in the posterior limb of the internal capsule. Then they all travel together through the brainstem and go on their merry way. So that's why you can have a stroke at just one little spot here and knock out the entire side. All right, back to our question. We've talked about the important things you need to know for this. Now it's just a matter of memorization. Do you know the arteries that supply things? Well, based off of what we just discussed, what we just drew, we know it's not going to be middle cerebral artery. It's not going to be an anterior cerebral artery for sure, because that would just be foot, leg. That would just be lower extremity. The rest is memorization. I would recommend getting this in Anki. It's going to help you on stroke questions. The lenticulostriate arteries are branches off of the middle cerebral artery. So you might argue, yeah, maybe the MCA is affected, depending if it's really proximal in the MCA. Right, so you've got your MCA looking something like this before it goes to supply the cortex over here. And then it shoots off little lenticulostriate branches right into our internal capsule and deep brain structures. And so if you had a stroke or an aneurysm, something affecting here, then it could hit our cortex and the internal limb for sure. And so that's when you might start to see things like the right face, arm, leg, and then the aphasia, neglect, visual disturbance, any other cortical signs that aren't just pure motor. But since we don't have that, we just have our pure motor signs, it is probably exclusive to the lenticulostriate vessels. So the correct answer is E.